their time to do this for us. So we're
dynamometer, surface EMG, evaluate and optimize human movement, capacity, and performance. And his primary goal in treatment, and it's very evident with how he treats his patients, it's to empower his patients and to help them overcome their injuries, mitigate future injury risk, and to return to full capacity. So we are very honored to have him here today, and I will turn the time over to you, Michael.
Great. Good morning, everyone. Thanks again, Chelsea and Minnie, for the invitation to speak today. It's a topic that I'm excited about to share, and I think that it's underutilized in the upper extremity. A lot of the research has been predominantly in the lower extremity. And so, yeah, I think it's really timely as more evidence has been coming out over the last, 5 years or so, where they've started to apply this to the upper extremity. So thank you again. I'm excited to be able to share the information with you. I'm going to start off by sharing my screen. Let's see. Let's do that. Okay. And you guys can see a browser at the moment, yes?
Correct.
So in the chat section, I had posted the link to this, and this is just a shared folder that has some of the resources from today, as well as the pre-material that I had sent out, should you want to go back and look at that or want to take notes. So the three primary things here are going to be the slides for today, the slides for the pre-content that I had sent out, and then also there's like a practical lab manual that was hopefully sent out to you ahead of time. Additionally, I just want to take a moment to thank those who had responded to the questionnaire that I had sent out ahead of time as well. That was really helpful to get a pulse as to what people were looking for, as well as the background. And I just wanted to take a moment and share the results with you all. So we can see that the majority of people are in a hospital-based practice, about 65% of those attending today. 75% of you have over 10 years of experience, so well-seasoned clinicians. These next two questions were really pertinent to me as far as trying to tailor today's content, is that 96% of people have not taken a certified course, about the same percentage don't really utilize BFR in the clinical setting. So we'll kind of, with that understanding, I really wanted to kind of go through some of the foundational principles of it and the application. And then when we look at the familiarity and your overall comfort level and with the documented effectiveness and et cetera, again, we're kind of on the lower end of the spectrum there. So thanks again for taking the time to fill it out. And then if we're going to prioritize things that are really meaningful to our audience today, so mechanisms of BFR, clinical application, the current evidence and effectiveness. So number 1 and number 3, I tried to address with the voiceover that I sent out ahead of time, though we'll touch upon it today. And I really wanted to spend our time predominantly talking about the clinical application and taking you through what I recommend to be kind of a clinical decision-making algorithm as far as screening out safety, and then the actual application, exercise prescription, and so on and so forth. And then, obviously, if there's questions that come up, feel free to put them in the chat. I probably won't deviate in the moment to answer them, but it may foster discussion at the end. So without further ado, I'm going to pull up my slides. Let's go from the beginning. Just want to make sure that we are all systems go. You guys can see what I see, which should be the opening slide of practical application of BFR restriction training. Yeah?
All looks good.
Great. So let's see if this... Yeah. Okay. So thank you again for the Hand Therapy Association of California, as well as to the Educational Committee co-chairs, Minnie and Chelsea, again for the invitation. And then the resources that I had shared, again, I just put together a slide so that you could otherwise easily access those if you lose the link that I sent in the chat. this is what I'm hoping to get through today. So really three sections, if you will. The first two are going to be me kind of talking at you, and hopefully it's stimulating enough despite the asynchronous format. And then I'm really excited about the group discussion, which I'm hoping to leave about 20 minutes for, given the hour and a half time frame. So it will probably be about 70 minutes of me kind of going through the presentation, and then we'll open it up for further discussion, questions, etc. So some of the objectives that I'm hoping you get out of today. So I want you to be able to describe an algorithmic decision-making process to identify appropriate patients for BFR, utilize the best evidence, though you're not going to actually perform a limb occlusion pressure, having an understanding of what that looks like, especially if you don't have an industrial pneumatic tourniquet that does it for you, determining the optimal occlusion pressure and exercise parameters, and verbalize the evidence and criterion-based clinical progression of what blood flow restriction training may look like in the upper extremity. Yeah, I kind of like objectives more so in the form of questions. I think that it really sparks a little bit more like mental and cognitive engagement. And so I've just reformatted here. These are the questions that I'm hoping you're going to be able to answer by the end of it. So what is BFR? How does it actually produce the set adaptations? I sent out that pre-material that really goes in depth on a cellular level as far as the mechanistic pathways and cellular pathways. What do you consider using BFR and on who could benefit? What does the evidence say about the effectiveness? Again, that's predominantly the pre-material. And more importantly, how do I safely apply BFR in the clinical setting? Some sub-questions there. Is it truly safe, and for who? What are the risks and side effects? How do I know if my patient is appropriate? And then the clinical and practical applications. So the reality of it, right? There are like 99 systematic reviews to date. I am not going to go through all those today. I'm just going to touch upon the surface. I feel the necessity to tell you the disclaimer that this is a growing field exponentially, particularly in the upper extremity, as I alluded to. And so I'm hoping that it gives you enough to be literate with the modality, as well as getting a good idea as to where you can continue to learn independently of today. So let's define the problem. So injury and immobilization leads to increased pain, increased inflammation, decreased tissue integrity, decreased thresholds, and mechanical stimuli. Secondary to this, the implications of the injury and immobilization leads to increased muscle atrophy as soon as within 5 days. Muscle strength decreases by up to 15% within the first 2 weeks. If you're at a decrease in activity levels longer than that, specifically up to 3 weeks, it's a 21% decrease in muscle performance, endurance, power. Tendon stiffness and cross-sectional area decreased by 30% within 21 days. And then the neural excitability and the neural drive decrease even at a faster rate within the first week. So, it is a problem that we're up against, and especially with the pain and the immobilization and the inflammatory process, that a lot of times our patients can't really they can't tolerate what would be traditional means of exercise and or manual therapy. Even at times can be somewhat tapered due to the fragility of the tissue tolerance. So with the hopes of having a multidisciplinary approach within your practice, I think this is a potential tool within your toolbox to be able to help to overcome the problem that we currently face. So defining blood flow restriction training, it entails applying a tourniquet-style cuff on the proximal aspects of the limb. It always goes on the proximal aspect of the limb. Even if you're going to be working on the wrist, it's going to go as close to the axilla as possible. Same for the lower extremity, should you so choose to use it there. Even though you may be focusing on the hand, there are potential benefits systemically that could benefit, the individual could benefit from using it on the lower extremity as well for upper extremity application. We can talk more about that as we go along. The cuff is tightened, hopefully through a pneumatic inflation. a pressure that occludes the venous flow, yet arterial inflow is allowed partially. So you're not allowing any backflow or return to the heart. You're really trapping the blood as well as the metabolites that accumulate due to the exercise within the limb. And here's a visual that I think hopefully helps you. It certainly helped me. So just looking at some of the legends there. So I'm going to use the deflated cuff in gray, the inflated cuff for black. Arterial inflow is going to be the candy cane striped arrow, and then the venous blood flow is going to be the clear arrow. And then the little star there, or asterisk, is going to be a metabolite. And then down at the bottom, you can see that this corresponds to motor neurons. And then the circles are going to be the muscle fibers. So the application of the cuff deflated looks something like this, where you get the equal inflow of arterial blood flow and the equal outflow of the venous, and the metabolites are able to cross that said barrier of the cuff. We can see that there's partial active motor units. Some of them are engaged, but none of them are really fatigued. Some of them are a little bit more active than others. So we go on to inflate the cuff, and we can see two things happen with the inflow and the outflow. So the inflow diminishes by a certain percentage depending on the amount of inflation, and there's no outflow. And thus you get this buildup of metabolites as indicated by the small stars. Additionally, we start to induce fatigue within the motor units as well as within the muscle fibers. And we can see that more motor units come on board such that our EMG increases, which is actually a key surrogate for the amount of work demand that is being done by the limb or the individual or the muscle in question, the tissue in question. Continue on with your exercise, and this just further augments, where we get hyper concentration of the metabolites, we get more fatigue in the motor units, greater onset of the like the number of motor unit pooling. So usually we talk about the size principle, and that we start with smaller motor units and gradually get to our type 2 and larger size motor units as the intensity of an exercise goes on. By inducing a hypoxic environment, we're able to somewhat artificially ramp this up or expedite the process there. And we also eventually want to get to this state where we get as many motor units on board and active as possible. We really increase the hyperconcentration of lactate, the hydrogen ions, the acidity increases within the limb, and it really creates a concentration of CO2 ratio relative to O2 starts to also increase over time. And really we're trying to get to a fatigue state of the muscle fibers across the board within the muscle. That's interesting. Okay, so if we're looking at the high intensity resistance training versus the low intensity BFR. So there's two types of stimulus that can induce these changes biologically. We can think of grossly, we can think of it as metabolic stress, which is the hypoxic environment. And if you went on a long run, or if you had someone do an arm bike, for instance, that would be your metabolic stress. Mechanical tension is doing like a 1RM grip strength or a 1RM bicep curl, and that's your more traditional mechanical tension. And so if we leverage the amount of metabolic stress, either high or low, or mechanical tension, high or low, that really starts to look at the stimulus as to what induces the changes in these two different settings. So I have 8 variables that would otherwise be altered with a stimulus, be it metabolic or mechanical. Right, and it's not an all or none. All right, it's not just mechanical tension or metabolic stress, regardless of which one you're looking at, high intensity versus BFR. It's usually along the spectrum. But what we can see is that for your high intensity, you're going to be it's going to be relatively low metabolic stress, but high mechanical tension induced. As I alluded to with our problem, right, we can't really induce those high mechanical tensions just because the fragility of the tissues that are healing, the pain, the inflammation, the patient's overall tolerance to it. But what we can do is we can significantly reduce our mechanical tension. That is, using a fraction of the weight or no weight in some instances in regards to the mechanical load that we're putting on the tissue. But we can really start to leverage this metabolic stress as indicated by the schematic that I showed in the previous slide. And what we look, if you look across these 8 different variables, is that there's a lot of consistency, where we're able to actually still induce a lot of fatigue, a lot of tissue adaptation, though there, you can see some discrepancies between the high load and the low load BFR, specifically in the muscle damage and the mechanotransduction, like which is the transmission of high mechanical tension within the tissue and within the cellular wall, which otherwise induces genetic expressions and thus the tissue adaptations. Which, though if time goes on and cell swelling increases, more evidence recently has come out to suggest that there is a pathway there for the mechanotransduction to actually take place. Muscle damage is usually on a lower end, as you're not really rupturing the muscle cells like you are with your higher mechanical tension. And thus DOMS is a little bit less depending on the training age and condition of the individual. But really across the board, the heat shock proteins, systemic and localized hormones, these all significantly increase, comparable to that of high mechanical tension. We get autocrine and paracrine actions, which then leads to muscle hypertrophy. However, it's not just a muscle experience from an adaptation standpoint, which I alluded to in the pre-material, and I'll allude to again in the coming slides, is that there are several tissues, almost every tissue that you look at within the limb or within the distal to the cuff and within the hypoxic environment is going to respond positively to this. And if you look back at Nobel Prize laureates, even as of 2019, one of the Nobel Prizes was looking at cell-induced changes to hypoxia. And a lot of those mechanisms that are identified within that research is readily applicable to the BFR research as well, just on a more cellular and benchtop level. Okay, so really there on a high level, there's really predominantly 4 pathways. So if we run with that last environmental image that I had showed with our schematic, right? You have the hypoxic pathway that you can see the different cascades. I'm not going to go into the details there, but at least the anabolic signaling, increased myogenic stem cell proliferation, myofibril hypertrophy, and increase in lactic acid levels. We have a hormonal pathway, which that lactate and that low pH within the cell, within the interstitial fluid of the occlusion, leads to a cascade of hormones that are released from the pituitary gland and more centrally. We have the intramuscular swelling, so the actual distension of the muscle cell acts as a signaling pathway for MAPK, as well as the mammalian target of rapamycin, or mTOR, to promote protein synthesis. And then we have the mechanical stimulation pathway, which is what I was alluding to with the mechanical transduction. Within this, there was a couple things that I do want to highlight, which I thought were really interesting. That there are unique properties and unique adaptations from blood flow restriction training that don't really apply necessarily with some of the high intensity resistance training. One of those being the endogenous release or stimulation, if you will, the activation of the myogenic stem cells. So when you look at this versus high versus low resistance training, low resistance training in the presence of BFR, that is. So I'm not the study Nielsen in 2012. So what you're looking at in the light gray shade bars there, we won't go into the details of the y-axis and explaining the PAX7, but that is a surrogate measure of myogenic stem cell activation. And you're looking at, in the A figure, you're looking at type 1 muscle fibers versus type 2 in the B figure. And what they are showing is pre-BFR, that is 8 days into the training, 3 days post, and 10 days post, that during the 3 days post and in the mid after a single week of blood flow restriction training, you're looking at close to 270 to 290% increase in the stem cell activation, which is pretty impressive, especially when you look at that versus the control. Even at 10 days post, you're still able to augment the amount of myogenic stem cell activation by 240%, which doesn't necessarily happen, right? We see this increase in myogenic stem cells for context in high load resistance training close to about 70%. So, I know there's a lot of buzz these days about biologics and stem cell injections, and whether you want to fly to Mexico or wherever you're going to get your stem cell bolus, you can also readily get it through more of an endogenous mechanism via the blood flow restriction training to some extent. Additionally, within the mechanical stimulation, jumped a little bit. All right, so blood flow restriction training, strength training displays high functional and biological efficacy in women within subject comparison and high load strength training. And so what you're looking at is a crossover design. So the same individuals did 12 weeks of blood flow restriction training as well as high load resistance training that resulted in similar gene expression. So they looked at 29 different genes that are all associated with skeletal muscle function. And after a single session, so they looked at this after the first session, and they also looked at after 12 sessions, 12 weeks. So after 24 sessions, all the gene expression was similar. So even on a mechanistic cellular level, at the mRNA level, that we're getting comparable benefits in our patients immediately. That could be post-operative after and or during immobilization, which is, again, it's just going to expedite the healing process. And if it doesn't even expedite, it's certainly going to cut the effects of immobilization that we have previously spoken about in our problem slide. The other thing that's really interesting to me is muscle fibrosis. So at least in the lower extremity, within the first week, even the second week, it gradually increases. I'm sure that the evidence is prevalent in the upper extremity. Given at least my clinical expertise in the lower extremity, I'm a little bit more familiar with this. But myelofibrosis sucks. Right, so it's hard. It creates hard fibrotic tissue that's inflexible. It's less functional. It's increased joint loading as well. I'm sure that you've had patients that where you're trying to activate a particular muscle group or even maybe a specific muscle, depending on the granularity at which the exercise is trying to be targeted, and they're like, it's active. I just don't, but they'll say that I just don't feel it. So I get it a lot with arthrogenic muscle inhibition of the quadricep, and in part, one of the reasons is for this cascade of just fibrotic tissue, and which is really due to the uptick in myostatin expression post-immobilization and due to the controlled trauma of the surgeries and or the knee pain and so on and so forth. But what is impressive and what has been shown is that through the mechanical stimulation in the presence of blood flow restriction trainings, that we get a downregulation of myostatin, which is good, which not only helps to preserve muscle mass, but then it also helps with this fibrotic effect that occurs within the muscle tissue, which once you get this fibrosis in place, it's not like though it occurs acutely and rapidly, the effects last months, potentially years, depending on the extent of the rehab and so on and so forth. So the fact that we have a modality that can help with our stem cell activation, look at gene expression, and then also counteract some of the fibrotic inflammation that occurs in the presence of immobilization, controlled traumas, injuries, and so forth, is certainly exciting for me. And I think more evidence will be coming out about this, particularly in the upper extremity, as I was alluding to. So the state of the current literature, right? So you can do, grossly speaking, you can do active or you can do passive BFR. If we look at the current research categories, if you will, of the cohorts, load compromised versus clinical population, the load compromised and healthy, right? So you have just differentiating the two. So you have load compromised and clinical population, but then you're also going to have some research that crosses over and looks at certain conditions with a healthy individual, and then you also have a healthy and athletic population. So it would look like this. So the established methods traditionally have been active, where you're looking at low load resistance training and or aerobic exercise. I appreciate the fact that they're the little infographics are demonstrating lower extremity, but the same thing would apply for upper extremity application as well as for an arm bike, for instance. And then developing methods and research have been looking at this like aerobic at high and moderate intensities, and then also in an ischemic preconditioning and remote ischemic preconditioning, which is the RIPC and the IPC for short, in this clinical population and those that are load compromised. In healthy as well as compromised, they've looked at this passive, so during rest or joint is otherwise immobilized, and or in the augmentation of muscle activation via NMES has also been coming out. And more what you're going to start to see is this hybrid, this infiltration, and this integrated approach of high load resistance training, looking not only at BFR in the presence of rehab and injury, but how can it actually enhance performance? And that's going to be more in your athletic and your healthy population. Okay, so I obviously indirectly alluded to why you may consider using BFR and for who. I'm not going to go in depth with this slide because I went through it in detail with the pre-lecture material, but if we look at any one of the different systems, it's not just muscle, even though you get a lot of social media and a lot of branding and marketing for the muscle and muscle strength and muscle hypertrophy. It's really on a systemic level that BFR is having its effect. And you as a clinician, if you understand the mechanisms and the benefits that it can have on a multi-system and a multimodal means, I think you're going to find unique applications that are going to not only expedite your patient outcome, but also their experience and get the diminishing returns that come from injury. Okay, so why would we apply BFR more on a larger or macro scale rather than just the specific biological systems that I showed in the last slide? So soft tissue injuries respond really well to this. Proximal injuries, potentially at the shoulder. Bone injuries, be it ORIF or non-operative, we consistently see positive adaptations to bone. Those that are post-surgical, as I alluded to in the lower extremity experience, but certainly in the upper extremity. Those that are anabolically resistant, so your older adult who is potentially experiencing atrophy or deconditioning due to their specific upper extremity injury or due to systemic aging or inflammaging, as they say, or other non-communicable diseases that make it difficult for them to otherwise induce positive tissue adaptation. I consistently will quote in clinic that strength is really never a weakness, and weakness is never a strength. We need a early and often we need to be able to facilitate positive muscular adaptations, not only from just the physical function of the individual, but also from a metabolic health. And certainly the individual that is otherwise immobilized, and using the application of the ischemic preconditioning, as I was mentioning, which we'll go into the parameters in that, but essentially that's utilizing the cuff in the absence of exercise, where you're just inflating them and deflating them in a cyclic fashion. Once again, I went through this slide in the pre-material. I've listed off the variety of different conditions clinically of why this would be applied in chronic kidney disease, male or female, those are older age, the athletic population, idiosyncratic bone response and positive new insights for bone adaptation, bone stress injuries. I know there was a question that came through in the questionnaire of repetitive stress injuries for the upper extremity, though I wasn't able to find anything specifically in my soft search of the literature that applied to that. Certainly, depending on the mechanisms that are at play that are hindering someone from able to do their repetitive actions, be it typing or computer work and so on and so forth. I certainly think that if they are load sensitive, be it in frequency or magnitude, then a metabolic training stimulus that is using a fraction of the load may certainly be beneficial. As I consistently kind of show off some of the titles here, you can see that it really runs the gamut as far as those that have been blood flow restriction training has been applied to COPD, to your cardiovascular compromised, hypertension, those with coronavirus, those even in space flight where you're in a microgravity environment. These more recent papers in chronic heart failure and disease are really interesting to me, and particularly within tendinopathy. Really, it is a matter of thinking about the mechanisms, understanding what the tissue adaptation is that you're trying to induce in your patient, and really understanding what are the precautions. Really, not so much who could benefit, but who should I not apply this to? And I think that question lends itself more so to our upcoming discussion. The efficacy, the effectiveness, the evidence of BFR, I encourage you to go back to the pre-material because I not only went through some of the highlighted systematic reviews of the 99 to date that have been conducted, but then I kind of cherry picked certain specific upper extremity as well as lower extremity randomized controlled trials and clinical trials that have been done to date that I consider to be seminal, that really demonstrate the effectiveness, the efficacy within the clinical and the non-clinical population. So let's talk about safety, risk stratification of BFR. And I don't know, I kind of like structure. It helps me to organize and have mental models. And so maybe it also resonates with you, but we're going to go through a 6-step process. That's kind of how I've organized it. So the first one we're going to talk about is screening, precautions and contraindications. And so a BFR screening algorithm is one of the things that I provided within the manual. If I shift this over, can you all see that? It will be different. So it's not the slide, but it's actually a PDF.
Yep, we can see it.
Perfect. All right. So this is the manual that I had sent out previously. So within this, I have kind of laid out the algorithm that we're going to go through. I've also laid out the screening questionnaire that we currently use in clinical practice here at Stanford Healthcare. We've done a retrospective analysis of over 250 patient encounters, looking back at any adverse responses that we've had. Out of the 250 encounters, we had 4. So our percent of adverse responses was quite low. The most significant of those of those 4 is like people getting lightheaded. We had one syncopal episode, which was actually on a clinician who was just hadn't eaten enough, if you will. So, adverse responses are a real thing, not only with blood flow restriction training, but really with anything that we do. But I think that you can significantly reduce any risk of that with this proper screening questionnaire that I've put out. And it's really more of a point-based system. I'll bounce back now to our slides. That will become questionnaire will become relevant here in a moment. So this is one decision-making algorithm that was put out by Scott et al. In 2014, right? So the question that you start with is, does the individual have any contraindications to BFR? Requires a clinician to consistently refer back to the contraindications and precautions that I had mentioned in that handout. And then if yes, it's maybe not a total no. There may be opportunity, especially if you collaborate closely with your physicians or referring physicians who are familiar with this, that there may be unique applications. For instance, as I mentioned in those clinical populations, you would see that someone with heart failure would probably be contraindicated, or those on our kidney and dialysis wouldn't be the first person that I would choose, but evidence would otherwise suggest within a controlled and safe environment in a structured program that they can actually not only get through BFR, but they can actually benefit from it. So consultation with your physician as well as your care team, I think, would be appropriate. Say that there's no contraindications and BFR is approved by your care team. Is this individual mobile? If no, apply BFR alone to said limb or limbs. That is, in the absence of exercise, assume that all patients who are immobile and aren't contraindicated should receive BFR, which is, I think, a little bit of an assumption. And then you can see if they are mobile, then you want to be doing more active exercises, and you can kind of follow the cascade there. The algorithm is biased towards BFR, in my opinion, so I've kind of revamped my own version, which I'll take you through. So the metacognition of BFR application for the clinician. The clinician should contemplate some specific questions before applying BFR. Is my patient like the patients in said study that I'm otherwise replicating, or the studies that BFR has been applied to? Does BFR have a clinical relevant benefit, i.e. improved function or hypertrophy, that outweighs the potential risk of the application? If yes, proceed with the screening algorithm. If no, reconsider and proceed with reconsider and proceed with other BFR means rather than BFR application. Okay, so here's the algorithm. Let's go through it in detail. On a gross scale, what it looks like is, can they benefit? What are my contraindications? Patient consent, MD consent, the active effusion and inflammation. Is there active effusion or inflammation? If yes, treat and control that first. Perform your limb occlusion pressure, and then determine your appropriate type of exercise to be applied is kind of on a broad scale how you could break this algorithm up. So can this patient's outcome be accelerated or improved? If no, continue with traditional rehab plan of care, which we know works. It doesn't have to be a BFR. Would the following physiological adaptations that we've spoken about, both locally and systemically, could they potentially benefit? And so with the assumption that we're not going to end this algorithm prematurely, we're going to assume that yes, they can. Does the patient have any contraindications? We would then go into our application of that screening questionnaire, which I'll pull it right up on the medical chart, stratify their point system using that questionnaire. So a score of greater than 4 would be contraindicated. Score 3 to 4 would be upper extremity only. Less than 3, it's onwards and upwards for any upper extremity or lower extremity. And obviously the lower extremity being a greater pooling of blood flow such that we would want to be conscious of that. And that's why there's a little bit of a stratification there. Okay, so then this is just a video that I've included as far as like how I apply it in our EPIC system. So I usually will use a dot phrase, which will populate the questionnaire. I'll, at the bedside or at the patient encounter, I'll just kind of run through the different contraindications. I'll say, stop me if any of these apply to you. And I'll just rattle them off and they're like, oh, yes or no. And that's kind of how I efficiently and effectively do it. The contraindication screening happens before patient encounter. And then the questionnaire that you see me scrolling down here is more the yes, no that I do with the patient. There are certain subsequent screenings that need to take place if they answer yes to any of the following. So hyperlipidemia or triglycerides, if they say yes to diabetes, yes to hypertension, yes to obesity, that being defined by our BMI greater than 30, and then if they are hypercoagulable. So at the end of the screening questionnaire are a risk stratification for those different variables of hypertension, diabetes, hyperlipidemia, high cholesterol, and then the obesity. And you can see the indications, those that are precautionary, and then those that are otherwise contraindicated. So let's talk about clotting, because that's a big concern for a lot of people when they first are applying this modality. In the first 6 weeks seen post orthopedic surgery, there's an estimated 100-fold increase in the risk of deep vein thrombosis, secondary to the combination of endothelial damage that occurs during surgery as well as the stasis. So 2 of the 3 conditions of the Virchow's triad, which we'll talk about here in a moment, are present. That's irrespective of whatever you're going to do, they're at risk by 100-fold. However, and some of them, obviously, if they have a risk of DVT and you can go through your Wells criteria, may have even a higher risk factor there. So your surgery, however, current evidence suggests that the use of tourniquet in surgery stasis does not seem to amplify the risk any further, and in fact, an increase in fibrolytic effect post-tourniquet, meaning they actually show that they can, some of the cellular mechanisms within the blood that help to break down clots are actually increased. And so when you're asking the question, can I apply a cuff safely to this postoperative patient, though there are certain variables that need to be taken into account, really what has transpired is this individual has been applied under full occlusion for 120 minutes or longer, which is 2 to 3 times the pressure given the width of the cuff during that surgery. BFR post-op, significantly less significantly less risk of the acquired VT than during surgery, and really you're just doing it for brief periods of time at a submaximal occlusion compared to what they've already experienced. So just looking at that as a comparison, if this individual, though obviously in a surgical suite they're well controlled and monitored, you are still able to do similar monitoring screening in the clinical setting that would otherwise ensure safety and application by comparison with the BFR. And to date, no study has provided evidence that BFR exercise amplifies the marked risk of the coagulative system. So Virchow's triad, let's talk about that briefly. So in order for blood clots to occur, you need these 3 things. You need hemodynamic changes or stasis, endothelial injury, and hypercoagulability. And so when we break that, what that actually looks like, so those that are stasis, we're talking about immobilization, paresis. Individuals who are greater than 40 years of age have an increased risk of stasis, varicose veins, those that are obese, heart or respiratory failure, stroke, spinal cord, so on and so forth. Hypercoagulability, this applies to individuals over age 70, those that have cancer, malignancy, pregnancy, postpartum. Thrombophilia is really one that you want to be conscious of, and that's in the questionnaire. We have the nephrotic syndrome, and then we have also active infection, and so so IBS. There's several variables there that could otherwise increase someone's coagulability. And then we have endothelial injury, which is your surgery, particularly around the pelvis more so than the upper extremity, but still obviously increased risk. And then we have trauma, smoking, previous DVT, and central vein catheterization. And so a lot of those screening questions are already in that questionnaire that I had alluded to. But in a surgical tourniquet setting, the VT, the deep vein thrombosis is usually listed as a potential complication, but a different correlation remains unclear. There have been cases reported of DVT and PE, however, risk remains low, and with proper screening, the risk can actually be negligible in the presence of BFR. And so I haven't seen the PE study. I know that the DVT were in cases that were the individual, if you look at the risk profile of the individual, it was otherwise inappropriate, but you really do want to do your due diligence in identifying whether this individual has a propensity of hypercoagulability, be it a platelet or other genetic condition that may predispose them to clotting or otherwise. And so you really need those 3 conditions in order for the clotting to otherwise be a true risk. But again, they're already at risk for DVT. BFR doesn't increase their risk. You just want to identify those individuals that have that hypercoagulability propensity. So as I alluded to, you get your scoring system. 4 or greater, you can't do it. Those that are 3 to 4, you have precautions. Lower extremity BFR, it should say upper extremity BFR only. And then patient consent. So that's the next phase. So if we've identified our individual to be either precautionary or full go with BFR, then we need to go through our consent with them. And so, yeah, it's kind of a funny conversation, I guess, kind of comical. So there's your patient, and you're like, I know what could help you. You're in a lot of pain and you're injured. Let's restrict your blood and have you exercise. And the patient's like, what? So the questions that usually come at you after you propose that is, what is BFR? Why would we do it? What is the benefit? Is it safe? What are the risks? My doctor didn't mention anything about you putting a tourniquet on me. What type of exercise should I do? Will it hurt? Can I do it at home? Can I just use any cuff to do it? How often do I need to do it? So you get a bombardment of additional questions from the patient that you need to be ready to be able to field. And the better that you know the science behind the modality, the better you'll be able to field these. And my workflow is that I've kind of created a frequently asked question or predictability of what they're going to ask, and I'll send that material ahead of time before we actually apply it first time within the clinical setting. And so I encourage you to either put together that FAQ, but just beware that you're going to have to do a little bit of salesmanship and fielding of those questions, because it really is kind of a deer in the headlights type look they'll give you when you first propose it. So you've convinced them, they've asked their questions, right? And they're like, okay, yeah, I'm willing to try it. So you've got your consent. The next party is this patient post-op or relative contraindications. You got to convince the MD. And so I've done I'm glad, at least with those that refer to me, at times they're up to date with the BFR. I've also put together templates that I've sent out to referring physicians who have given a little bit of pause to the blood flow restriction training. I think that more and more of the orthopedic surgeons and those referring providers, I've yet to see a primary care who has actually referred directly for it or is well versed, at least in the science. They may have heard of it, but certainly in the sports medicine department that I work with, they even will refer directly for that. So is this patient post-op, or are there relative contraindications, as I mentioned? Is the MD okay with it? If the patient education, you offer the risks and the benefits, they're like, no, right, continue with traditional rehab. If the MD is no, then I'm like, all right, well, let's have a conversation before we actually go on and really go through our traditional route, because I think that your patient could potentially really benefit. In fact, I think I can speak to their ego a little bit and say that your postoperative outcome of your patients will be better. Here's the evidence for that, and having that conversation and building that rapport with your referring physicians. So you've gotten through the patient consent, your doctor is okay with it, you've had that conversation. Is the patient post-op and the relative contraindications, is there active inflammation is your next question. So if yes, you want to hold off on BFR, you really do want to control the inflammation, the swelling, right? If their arm is, right, if they have to take all their rings and their watch off their limb because everything's in a distended state, right? Putting more pooling in place may not be the best action at that time, perhaps. So use your other modalities, your rest, your RICE, etc., pharmacological management, so on and so forth, and really control the joint effusion. And so here are some of the means by which I help with the joint effusion. I'm sure that you also have your suite and your buffet of the strategies that you use within your clinical practice. And then once that's controlled, if it is controlled, if still no, repeat, rinse, wash, and repeat. And then if it is, well, then you're looking pretty good. But I know one question that came up in the questionnaire was like, how early after surgery? I mean, people are doing this at times in the UK for total joints. They are doing it day one. I'm a little bit more lenient on that. I'm really concerned, particularly in my post-operative knee, for instance, of popping a stitch, right? The knee's already distended, and if I go occluding it and they bend their knee, right, you're just getting further further distension of the tissue. And I really think that controlling that inflammation to some extent is probably first and foremost before you go occluding the limb. But we also know that people muscle dump within that first 2 weeks. I gave the example, at least within the quadricep, that people lose about 350 grams out of their quadricep within 14 days. The size of your heart is about 300 grams. I'm sure that because of the muscles in the upper extremity are certainly less large and not gravity dependent or gravity resistant as much as the lower extremity, that the repercussions of immobilization may be less than that. But I would say that proportionally that there is still going to be that loss of muscle mass. And so you do want to control the inflammation as quickly as you can and apply the BFR as soon as you can. All right, step 2. Sorry, I went through that a little bit quick. So cuff application, location, and cuff properties. So this is the location of the cuff, as I alluded to, as close to the axilla and as close to the groin as possible. What is a pneumatic tourniquet? It is a medical device consisting of a pressure-regulated unit which can be operated manually or automatically. The purpose is intended to reduce the total occluded circulation to the patient's limb, as I demonstrated in that brief schematic early on, and that there's no return of venous flow. Note that this definition covers pneumatic tourniquets intended to restrict or completely occlude the blood flow to the limb, though we may do that with our ischemic preconditioning, where we completely occlude blood flow. Traditionally, in the active sense of blood flow restriction training, we're not occluding the blood flow completely. At least for the arterial inflow, we are completely occluding the venous flow. And what's the difference between a pneumatic tourniquet versus a blood pressure cuff? For patient safety, BFR's cuffs are especially, the pneumatic tourniquet that is used in surgery as well as BFR versus your blood pressure cuff, right? The pneumatic tourniquets are specially designed that allows the user to safely and accurately apply desired pressure level and gradient uniform around the limb for a prolonged period of time. Though you could potentially and theoretically use your blood pressure cuff, personally, I can't advise that. I think that that's a bit unsafe and a little bit rogue, but I'll let you make your own clinical decisions. So they are regulated and registered with the FDA. There's only a couple of them that are. And so here's an example, Suji BFR Pro. That's what you would want to look at. So you can see the cascade there. It says, I went to the FDA home, I went to medical devices, I went to the database, and then you can type in any one of those things. You can look at the actual manufacturer, or you can look at under general use pneumatic tourniquets, and it's listed alphabetically. But really the 3 questions a clinician should ask prior to deciding whether to purchase a particular pneumatic tourniquet. One, is the pneumatic tourniquet manufacturer registered as an established with the FDA? I think that that's really important, particularly if you're going to be doing it, you're going to have patients be doing it at home. It's really the wild, wild west as far as Amazon is concerned. And if you go on and type in blood flow restriction training, you're going to go get a whole slew of do it yourself or DIY tourniquets that are really kind of unsafe and even questionably effective. If it's not readily on the website, oftentimes they will market it. You can look it up in a database as shown, or you can reach out to the company directly. Often I've done that on several occasions with their Contact Us page. The other two questions that you should be asking is, can the cuff pressure be individualized to the patient? That's really important and specific to the particular limb. And then, can the cuff pressure be adjusted during either manual or electronically during the exercise? The cuff system should allow for manual and electronic control of pressure, just from a safety standpoint. Pressure autoregulation is where the cuff system keeps someone at a specific percentage of their limb occlusion pressure. In the upper extremity, it's specifically 50% of your limb occlusion pressure. As they contract and relax their muscle, the gradient within the vasculature and within the limb, the pressure changes. In autoregulation, the system keeps them at that specific occlusion pressure over time. That's a nice to do, not a necessity. Even having the manual pressure cuffs, as long as they're FDA approved, are appropriate. So when we're looking at the properties of the cuff, so some cuffs are multi-chambered versus single-chambered bladder. You can see in kind of the little cartoon animation there that you want the single-chambered cuff. Though they're multi-chambered bladders, the company will market it as safer. Yeah, so it does allow for venous flow because of the lack of homogeneous occlusion. But if one of our surrogates for determination that this is going to be effective is, one, the increase in EMG, which comes in a hypoxic environment, and with the buildup of metabolites, and particularly lactate, and the decrease in the pH, as well as the CO2 buildup. And if you have this multi-chamber system, then you're just allowing all those things to otherwise escape, reducing the concentration, and thus reducing the endogenous response to the training. The auto-regulation, as I mentioned, is certainly a nice feature and is offered on the industrial units and some of the home units these days, but not a necessity. And this is where it's going to maintain that pressure that you set throughout the exercise, versus when the non-auto-regulation, it's going to fluctuate. I've seen it up to anywhere between 10 and 20 millimeters of mercury up and down as the individual contracts and relaxes the limb. The curved and contour cuff is superior to that of the straight, just because it actually has a better homogeneous fit and provides a homogeneous pressure circumferentially around the limb. So these are the features that you're going to want to look for within your cuff selection. Some others that I think are noteworthy. So there's something called the set pressure versus the interface pressure. The set pressure is what you pump it up to. The interface pressure is what actual pressure is applied via the cuff. Sometimes these are not equal. You want to have the device be as close to those as possible. I actually haven't seen any cuff besides for maybe the industrial Delphi unit via Owens Recovery. They do market that their set pressure and their interface pressure is the same. I think that goes a little bit more granular than some marketing campaigns have actually gone through. But it's so making that decision using that variable to make your decision may be difficult because the information is not readily at hand. But I think if your cuff speculation, or the cuff that you select, meets all these other specifications, then by all means, I think that you're in a pretty good ballpark of the cuff being effective. Similar to what I was talking about with the multi-chamber, sometimes you get this partial bladder, as you can see there, as far as the partial versus the full circumferential bladder. Once again, similar to that of the single chamber, is that it allows for that homogeneous occlusion, and your target for the upper extremity is going to be your brachial artery rather than your femoral, but the same thing would otherwise apply. Other considerations are the nylon versus the elastic. The nylon I'm biased to just because the elastic allows for that recoil and that change in diameter of the cuff during your exercise. Wide versus narrow, the wider the cuff certainly allows for lower pressures. But the narrow cuff occludes less muscle mass, and so all the more tissue that is distal to the cuff, the better. Okay, so summary slide of what I just said. Where to put it, groin and axilla. It needs to be FDA registered. It needs to be a pneumonic tourniquet, single chamber, circumference bladder, curved cuff, sufficient widths for arms and legs. And then for the arms, it's more of a narrow cuff compared to that of the wider cuffs. I give some ranges there as far as the centimeter or the width of the cuff. And the auto regulation is a nice feature, but not a necessity. Some of the brands, so this is the gold standard, Owens Recovery Science, and they only sell to licensed practitioners, directed to consumers, the ones that I've endorsed because of them meeting the specifications that I just went through, and I offer my patients would be the links to these of H Plus cuffs, the Smart Tools, and then the Suji. The Suji and the Smart cuffs are auto-regulated, the H Plus cuffs are not. All right. We are at cuff pressure and specific to the individual pressure. So in the upper extremity, they've done the studies. This is 15 healthy individuals, non-randomized controlled trial. It was done in a laboratory-based setting. They looked at muscle activation, repetitions to failure, and the discomfort level of the cuff. The exercise protocols that were used. So they did 4 sessions, performing 3 common rotator cuff exercises as shown there, internal and external rotation, as well as scaption. And they did a single set to failure. And then the intensity used was 20% of the individuals, 1 RM. And they randomized the ordering of the cuff pressures at 0%, 25, 50%, and 75% limb occlusion pressure. What did they find? So let's take the, I'm not going to go through the EMG of each of these exercises. Let's just use the external rotation as a surrogate for all of them. So on the y-axis is the mean EMG relative to baseline. And you can see they looked at the EMG of those muscles around the shoulder. So those proximal to the cuff, certainly we know that if these increase in their EMG, that those distal to the cuff certainly have, depending on the exercise. This one obviously being with external rotation biasing the shoulder muscles, may have slightly increased EMG relative to your biceps and your triceps, your forearm, and so forth. But oftentimes you see an increase in the EMG of the proximal muscle groups after there's been sufficient fatigue distal to the cuff. But that being said, the take-home message here, really your eyes should fall on the 50 and the 75% bars that are consistently higher than the other bars, and that dotted line representing the same EMG as relative to baseline. And what we can see is that the ideal pressures are going to be either equal to or greater than 50%. So you could use 75%, but the reason why you may not to is because there's diminishing returns. Specifically, you're looking at discomfort rated from 0 to 10. You can see as pressure increases, not surprisingly, that particularly that 75% pressure that people are, depending on the exercise in question, right, they're close, at a minimum, they're at a 6 out of 10 discomfort with the higher pressures versus something that's a little bit more moderate, a little bit more tolerable, which would be 4.5 to 5 with the 50%. And then if you're looking at reps to fatigue, right, so you also get diminishing returns in someone's workload capacity if you get to the higher occlusions of 75%. So you're looking at, on the y-axis, again, repetitions for fatigue, the different pressures as demonstrated by the histogram bars, and then those per exercise. Conclusion is that diminishing returns greater than 50% LOP. So ideally you want to be using limb occlusion pressures of 50% of what the overall, I guess I made the assumption that I defined limb occlusion pressure. Limb occlusion pressure is that which completely occludes the blood flow to the limb, is where you do not get any further pulse of the arterial flow. Okay. So you've identified your individual. You need to then, depending on the unit that you have, you may need to go through using a ultrasound Doppler. Particularly, it's shown here in the lower extremity, but it's more relevant for this context today. Is using the brachial artery at the as shown here. So you're gonna occlude the brachial artery. You're gonna go down to the radial pulse. You're gonna use your Doppler ultrasound. You're gonna pump up the cuff to the point where you don't get a pulse anymore. That would be your LOP. You diminish the pressure of the cuff to 50% of that LOP, and you're ready to exercise or do your BFR. So let's talk about the parameters, right? So if yes, this patient can perform active exercise, great. If they can't, then you're going to do your ischemic preconditioning protocol. If they can tolerate exercise, but you may want to start initially with low intensity cycling or walking. So maybe you just put them on the arm bike, or maybe you just get them acclimated to it with lower extremity walking on the treadmill, and then you initiate the low load BFR 1RM once they are a little bit more tolerable of the modality. And if they can this patient tolerate greater than 70% 1RM? No, then you're kind of consistently utilizing the BFR at 20 to 40% 1RM. And then you're going to combine, if they can, then you're going to combine the low load BFR with high load resistance training. Again, understanding that they have different physiological adaptations, though they're similar in their clinical outcomes as far as high load versus BFR. There are, again, you're not going to get the myogenic stem cell activation. You're not going to necessarily get the angiogenesis, the 43% increase in blood flow over 4 weeks, as far as like the sprouting and the additional vasculature that is shown with the BFR in the high load resistance training group. Sorry, that was. So the summary of the algorithm. Right, so as we went through, can they benefit? Your contraindications, consent the patient, make sure your doctor's okay with it. First, you need to control your inflammation. If you can, then you're going to perform your LOP. You're going to determine your appropriate exercise, and then you're going to go into your exercise parameters. So let me go through the exercise stimulus type of exercise and the dosage, which will be brief, and then we'll have our discussion. So occlusion variables, cuff application, we've spoken about where you're going to put it and how you're going to determine what cuff type to use. Your limb occlusion pressure for your upper extremity is going to be 50% LOP. If you're using your ischemic preconditioning, that is you're doing it passive, then you can use higher pressures of 80 to 100%, even in the upper extremity. And then with your exercise variables, so type of exercise, your frequency, your exercise intensity, your volume. If you're going to do it passively, it's going to look like this. You're going to do 5 rounds of 5 minutes. So you're going to pump them up to 80 to 100% of occlusion relative to their LOP. You're going to rest 3 minutes in between your during your deflates of those 5 minutes of occlusions. You do it up to 2 to 6 times per week. There's no tempo associated with that. For your aerobic, being your upper extremity arm bike or you're walking on your treadmill, clinical populations, you're going to be doing it 2 to 3 times a week. Athletic populations, you can get away with 3 to 4 times per week. Exercise intensities, you're going to be looking at 40 to 60% of their heart rate max. If you're not calculating that, you can use RPE. You can use RPE also in reps in reserve for your resistance training prescription as well. Typically, you're going to be doing your aerobics for about 20 minutes. For your resistance, it's going to be 4 sets classically per exercise with no more than 5 exercises, 30 repetitions followed by 15, 15, and 15 with 30 seconds rest in between your sets and 1 minute rest in between your exercises. Active exercise regimen should last 6 to 10 weeks, but you're really trying to bridge the gap to your higher load resistance training and or higher intensity forms of rehab. Your tempo, your RPMs are based on resistance and RPE. Usually I try and get people, at least in the lower extremity, to hit a 60 to 80 RPMs. You could also use wattage, which takes into account both the RPM as well as the resistance. And then for your resistance training, your tempo is about 2 seconds through your eccentric, 1 second isometric, 2 seconds concentric. So about 12 reps per minute. Okay, so I've talked enough. I think there's certainly more material to go through, and we can talk about the monitoring and the progression. But I've also provided that content available to you. So I think I'll just kind of pause there, and we'll have maybe 15, 20 minutes here for open discussion. I'm sure that there's questions that have populated, and if not, I can certainly keep talking. But let's stop sharing the screen for a second.
Thank you, Michael. Everyone, go ahead and start putting your questions in the Q&A box, and we'll start fielding those as they come along.